We are starting here in this Shaukat Sadikot Hall our first inauguration program. So we have already with us Dr. Professor Azad Khan, who is chairing this session. Can I have, Dr. Azad Khan and Dr. S.R. Arvind, who are there? Can I have their slide? So we know that Professor A.K. Azad Khan is currently chair-elect for Diabetes IDF Southeast Asia region. Currently, we have chair is Dr. Shashank Joshi, and Dr. Azad Khan is professor of diabetology, and he is also the chair-elect for IDF Southeast Asia region. He is from Bangladesh. He is also FRCP and FCPS. Professor Azad Khan is a very senior diabetologist, and along with him, we have with us Dr. S.R. Arvind, who is President of Diabetes India. He is Director and Chief Diabetologist of Diacon Hospital, Bangalore, India. Now over to them for our first session.
Thank you, Dr. Banshi, and it's a pleasure to be sharing this.
Can I add something? Banshi has introduced me, but he hasn't said the most important thing, that I'm a friend of Banshi and Shashank.
Thank you, sir. Thank you.
Thank you for being there for us, Dr. Azad Khan. And I think to take this, the first session going, I think I'll request Dr. Azad Khan to take over from here, and I'll always be there at the back to support him. So he will be the main chair for this particular first session, which is a virtual meet. Over to you, Dr. Azad Khan. I request all others to mute so that there's going to be no disturbance, please. I request... Sir,
remote call. I would like to humbly request you to continue chairmanship. I'm with you. I'm in a very remote corner of Bengal. I'm in the south, quite near the sea. So I will be with you, but please continue chairing.
Okay.
Thank you.
May I request the RX events to come out with the program, the first program, and then to start off. Do we have the speakers or are they recorded lectures?
So Arvind, Inas is the first speaker, and you can introduce her, and then we can...
Is Dr. Inas live, or is it a recorded lecture, please?
Recorded lecture is there.
Live, sir.
Okay, she's live. Okay. Welcome, Dr. Inas Shalaut, and she's a professor of internal medicine and diabetes from the Cairo University. She's been the chairman of Unit 4 Internal Medicine Department at the Cairo University. She's the president of the Arabic Association for the Study of Diabetes and Metabolism. She's the honorary tutor of diabetes at the Cardiff University, member of the European Association for Study of Diabetes, Egyptian Society of Internal Medicine, Egyptian Society of Nephrology, Egyptian Society of Diabetes, and Egyptian Medical Association for Studying Obesity. And I welcome Dr. Inas Shalaut, and then she will be starting her first lecture now. I mean, I don't see the faces on this virtual platform, so I don't have a speaker's view here, and it's a gallery view. So may I request the RX events to show Dr. Inas live, please. Yeah, she has just been introduced.
Sir, Dr. Inas' talk is live, and I think ma'am is not joined.
Has she joined?
Can we move on for second talk? Dr. Rayaz sir is joined.
Absolutely fine, and I think we can follow that up with the lecture of Dr. Inas. We'll move to the second one, and okay. So I think what we'll do is by the time Dr. Inas actually comes on live, I would like to start the first talk of Dr. Rayaz Malik. He's the professor of medicine at Qatar, Vale Cornell Medicine. He's the Associate Editor of Scientific Report, PLOS One, Frontiers Endocrinology, and Frontiers Neurology. Welcome, Dr. Rayaz. Can I see your live video there? Yes, I can see your live video, sir. So thank you so very much for joining us, and I'm sure it's going to be pretty early over there. And You will be talking about the diabetic triopathy, and that's going to be a very interesting first talk. The stage is all yours, sir.
Thank you and good morning. And thank you to the, of course, the organizers, Dr. Shabu and the chairpersons. So the talk that I've been asked to give is on the diabetic triopathy. So it's an update on really the management of the three major diabetes complications. And these, of course, are retinopathy, nephropathy, and neuropathy. But if anybody knows anything about me, then you will know that neuropathy is my area of expertise and interest. So unlike other speakers who would start with retinopathy at the top and then nephropathy and finally remember a little bit about neuropathy, I will start with neuropathy. In terms of neuropathy, I think it's important to remember that the risk factors for diabetic neuropathy are not simply glycemic control. And this is a key paper from now over 16 years ago, which Solomon Tesfaye published in the New England Journal of Medicine, where they showed that the risk factors for diabetic neuropathy, that is damage to the peripheral nerves, is very much I would say a vascular complication, because hypertension actually was the biggest risk factor. And then also other cardiovascular risk factors like being overweight, like having higher triglycerides and higher total cholesterol were contributing as much towards diabetic neuropathy as glucose control. And actually, with that comes a Cochrane review, which looked at the benefits of enhanced glycemic control in terms of outcomes in trials in both type 1 and type 2 diabetes. And what did they show? Well, they showed that in type 1 diabetes, predominantly driven by the DCCT, that improving glucose control improves neuropathy. However, in type 2 diabetes, and these were studies which included the Accord study, the UKPDS, part of the UKPDS, and VADT study, there was actually no significant difference. And people, when they looked at this data, they thought it can't be true. And I think it is true, but it's because of reasons. And the two reasons were, I believe now, one, that the therapies that were being used at that time in patients with type 2 diabetes were not good enough or didn't have a targeted effect on the nerves. And two, the way they measured neuropathy in the two different trials was different. That in type 1 diabetes, they used highly sensitive tests like nerve conduction. In the type 2 trials, they actually used very, very rough and ready tests like clinical examination, monofilament examination. So that's part of the reason. And actually, then something happened about 2018 as a sub-study of the liraglutide LEADER trial. There was, I would say, tenuous evidence, but nevertheless, there was something to suggest that GLP-1 therapy might have an impact on diabetic neuropathy. So first of all, actually, they looked at the incidence of foot ulceration, and they showed no difference between liraglutide and placebo, about the same over the period of 5 years. However, when they looked at, of course, the dreaded outcome of diabetic neuropathy, which is amputation, and this is Mr. von Bergmann from Berlin, 1901, what they showed is that there was a signal, statistically significant, in terms of people who had foot ulcers going on to have amputations was reduced in those who were on GLP-1 therapy compared to placebo. Of course, placebo wasn't complete placebo because these people were also being treated with standard therapy, suggesting that there may be an impact of GLP-1 therapy. Now, subsequently, in Qatar, we actually were part of a trial called the Qatar study, where essentially poorly controlled patients with type 2 diabetes with average HbA1cs of 10.5% were randomized to either GLP-1 once weekly exenatide with pioglitazone or basal bolus insulin. And we looked at the impact on neuropathy. And first of all, what you see here is that there is no difference between what we call combination therapy with the GLP-1 combined with pioglitazone and or basal bolus insulin. So both were effective in lowering HbA1c from around 10.5% to 7%. However, instead of using monofilament neurological examination, we actually used a very sensitive technique that we've developed over the years called corneal confocal microscopy, which is a rapid test that allows you to image small nerve fibers in the cornea, but is a surrogate marker of nerve fibers elsewhere. And what we were able to show effectively within 12 months was the following, that actually compared to healthy controls, you see here, these white lines are the nerve fibers. In both the GLP-1 and pioglitazone arm and the basal bolus insulin arm, there was actually repair of nerve fibers over 1 year, showing that actually a number of things you can measure in terms of these nerve fibers, so fiber density, branch density, fiber length, all improved significantly in actually both arms. But if you look to vibration perception, really in one arm it improved, in the other arm it didn't. So there was a kind of, it was just not good enough as a test. Then other risk factors, as I noted at the beginning, hypertension is an important risk factor for neuropathy. So this is an old study, but has been actually replicated by a number of studies subsequently, where we showed that if you give patients who are normotensive without microalbuminuria an ACE inhibitor, then if you measure nerve conductions, you can see that there is within 12 months an improvement in motor nerve conduction velocity, M-wave amplitude, and F-wave latency, indicating that treatment of people with normal blood pressure improves neuropathy. There is also a study, again coming back to vascular risk factors, a small study from Mexico, which compared rosuvastatin with placebo and showed that in the people treated with rosuvastatin, there was a significant improvement in nerve conduction velocity, perineal nerve conduction velocity of almost, well, actually 2 meters per second. The other measures didn't really change. Amplitude almost became significant, but nevertheless, there is some impact in a small study. And probably the most impressive data actually comes from the field study, where it was seen during the field study, which is a very large randomized trial in type 2 diabetes, where the cardiovascular outcomes were negative, but the incidence of minor amputation, you can see, was almost 50% reduced in people on fenofibrate compared to placebo. And that again suggests that there is an impact on neuropathy. And if we look at the other aspect of neuropathy, which of course is painful neuropathy, then what we have are data from the UK, the USA, which show that 1 in 5 individuals have painful diabetic neuropathy. This is a large study that we did in Manchester in the Northwest region of 15,000 patients in secondary and primary care. And we established a prevalence of 1 in 5 patients with type 2, predominantly diabetes, have painful neuropathy. However, if we look closer to the region that I'm currently working in Qatar, actually, we've done almost a similar study where in 1,171 patients with predominantly type 2 diabetes, we've shown a much higher prevalence of 34% as opposed to 21%. And particularly along with the Qatari Arabs themselves, the prevalence was even higher. And so we asked the question, why is the prevalence higher in this region, and why is it particularly higher in the Arabs? Well, part of the reason is because we've established that obesity is a major risk factor for painful diabetic neuropathy, alongside smoking as well. But the traditional risk factors like HbA1c, hypertension, for painful neuropathy, there is no risk. But the other thing that we showed, unfortunately, is that the majority of these patients who we diagnosed with painful diabetic retinopathy had not previously been diagnosed or treated. And that again shows that as physicians, we're not looking for painful diabetic retinopathy in 80% of these patients. In terms of choices of therapy, well, not much has really changed because not much has really come onto the market in terms of new therapies. So we still have the established therapies like pregabalin, gabapentin, or the SNRIs like duloxetine and venlafaxine, and of course the cheaper alternatives, which are the tricyclic antidepressants, but they do come with side effects. So according to the ADA, you can use either of these therapies, or you can switch to another agent if one isn't working, or use combinations, lower doses of combinations. Of course, pregabalin and duloxetine were approved in 2004. Subsequently, there have been two other approvals. One is tapentadol, which is the mu receptor agonist and partial works on descending inhibitory pathways, which is a cousin of tramadol, and that may be used. And most recently, the FDA has approved the 8% Quatenza, which is the capsaicin 8% patch for diabetic neuropathy. I must say, I have my reservations about this because I think this is not something that I would be putting on the feet of people with diabetes, because there are data to suggest that high dose capsaicin may in fact inflict damage to the small nerve fibers. The other thing that you might or I would want you to do is actually check the vitamin D levels in these patients, because what we and others have shown is that patients with painful diabetic neuropathy have lower levels of circulating 25-hydroxy-D compared to patients with painless diabetic neuropathy and healthy controls. And in fact, the level, if it's less than 20 nanograms per mil, there was a 9.8-fold increased risk of painful diabetic neuropathy. And if you had a level less than 30, it was 4.4-fold increase. And we showed this in Manchester, but in Sheffield, Solomon Tesfay's group showed exactly the same. Lower levels predict a diabetic painful neuropathy. And we, of course, previously, in collaboration with the Bakai Center in Karachi, did a controlled trial where we gave D3 600,000 international units intramuscularly, followed up over 20 weeks, and we showed a significant improvement in 3 different types of pain scores. But interestingly, the average level of 25-hydroxy-D in these patients was actually what one would say is relatively high. That is 31 nanograms per mil. And most people wouldn't treat this, but when we did treat it, you can see it went up to 46, and there was an improvement. The other aspect, of course, is erectile dysfunction. The ADA would want you to screen annually for erectile dysfunction with simple questions in the consultation. In terms of endocrinology, one should not in every patient with diabetes, because obviously sometimes it's obvious, but if you have somebody who's got, say, mild diabetic neuropathy, then assess the LH testosterone. And if the testosterone is less than 12 nanomoles per liter, then there is data to suggest that you get a benefit by treating with testosterone. The other thing you ought to do is advise patients to stop smoking, because ED improves by 25% if you stop smoking. And then, of course, we know there is a standard set of therapies, and there's nothing new here. PDE5 inhibitors are, of course, very, very effective, and there are different types, and you can give them daily as opposed to weekly. Statins also improve the erectile dysfunction score. And then you have other alternatives. In terms of retinopathy, basically, there are really, again, pharmacological approaches for retinopathy are glycemic control from the Accord study, where there was, as you can see, an improvement compared to the standard arm with the HbA1c of 7 to 7.9% compared to 6%. There was a significant reduction in the progression of diabetic retinopathy by 33%. And again, the fenofibrate story continues in that actually what people on fenofibrate in the Accord study had a 40% reduction in progression of diabetic retinopathy. Glucose control, interestingly, which people most think ACE inhibitors, ARBs are effective retinopathy, didn't show a benefit in the Accord therapy. And of course, in the field study, there were, if you looked at macular edema, proliferative retinopathy, and all retinopathy, there was a significant signal for people on fenofibrate that prevented progression of diabetic retinopathy. And based on that, actually, fenofibrate has a license for retinopathy in Australia. More recently, there has been a really big database that's been assessed in terms of fenofibrate effect on vision-threatening retinopathy. This is comparing 144,000 people not on fenofibrate compared to 5,000 on fenofibrate. HbA1c, interestingly, really reasonably well controlled. But what you see is the following, that vision-threatening diabetic retinopathy was reduced overall in multivariate analysis. You can see P is 0.01. And the predominant driver was the progression of proliferative diabetic retinopathy. You can see highly significant impact on the progression of proliferative diabetic retinopathy. They did assess for macular edema, and they did not find an effect. And that may be partly to do with how macular edema was measured in an insurance database, but nevertheless, they did not show an effect. So it seems to be not having as much of an impact on macular edema, unlike the field study where there was an impact on macular edema. In terms of nephropathy, of course, we have lots of people always think about lowering blood pressure in nephropathy has an impact. And there are many drugs that we can use. But of course, remember that really ACE inhibitors and ARBs are the main drugs that should be used in diabetic nephropathy. But what do you do when, despite being on an ACE or an ARB, you have adequate blood pressure control and the proteinuria is continuing? And really, also remember that there are actually no drugs to date that have improved the GFR. I will talk about drugs that might have stabilized the GFR, but no drug to date has improved the GFR except a drug which came with a lot of promise, but unfortunately got pulled because of cardiovascular events, bardoxolone sodium, which was basically NRF2 inhibitor, which is an anti-inflammatory. So I think we need to wait. Maybe there is something coming around the corner for that. But if you don't have these additional drugs, if you're already on an ACE or an ARB, then there is evidence to show that spironolactone overall further reduces urinary albumin excretion rate by 30%. In both type 1 and type 2 diabetes. And this is old data, again, 15 years old. And there is a Cochrane analysis which looked at 27 studies, which shows that aldosterone antagonism has an impact. So we know that it has an impact in terms of heart failure, cardiac fibrosis, but also it is being shown to have an impact in terms of renal fibrosis and hypertension, and having an impact on CKD. And we not only have spironolactone, but we have eplerenone and finerenone. They again show no effect on progression of GFR or renal failure or dialysis, but what they show is an impact in patients who've got stage 1 to 3 CKD. If you add one of these antagonists, you reduce proteinuria by a further 0.61 grams and you reduce blood pressure. But of course, remember, look out for hyperkalemia, gynecomastia, and in women, postmenopausal women, bleeding. What next? If you're, despite on being on an ACE or an ARB, you're on spironolactone 25 milligrams, you've still got adequate blood pressure control, but proteinuria continues. Well, something old, really, for something new. So this is a recent paper published in the New England Journal of Medicine in 2021, where patients had chronic kidney disease, predominantly diabetes, had a reasonable control of systolic blood pressure. Estimated GFR actually was way down, 23. And they were randomized to chlorthalidone or not. And what they showed is that there was a further drop in systolic blood pressure on chlorthalidone, but which went after discontinuation actually came back up. And there was a drop in urine albumin excretion rate, further drop. And again, that came up after it stopped. And eGFR, although it dropped slightly from 24 to around 21, you can see it remained stable and then it actually normalized again once chlorthalidone had been stopped. So ACE, ARB, spironolactone, chlorthalidone, what do? If it continues the proteinuria, you still want to reduce the proteinuria. Well, there are two drugs now, classes of drugs actually, that have been shown to have an impact despite being on these current therapies for lowering blood pressure. And those are the GLP-1 agonists, so liraglutide in the LEADER study, and semaglutide has also shown similar effect, where you can reduce progression actually of eGFR to less than 45, renal replacement, renal death. You can see here there is actually a 22% reduction in nephropathy in the LEADER study, but there is a small signal for retinopathy, which we ought to be aware of, which there are currently big randomized trials actually going on to have a look at this. And so far the signal is safe, and there isn't a worsening of retinopathy. Well, we're running out of options really, but there are options. So now we have one class of drugs, three different types of drugs, the SGLT2 inhibitors, which all show a further impact. So worsening nephropathy, you can see the EMPA-REG study, reduction with empagliflozin. And the other key thing that we are now showing is that instead of this progression of GFR on the SGLT2 inhibitors, we can actually flatten out the GFR. So that's empagliflozin, canagliflozin has the same impact, renal specific outcomes reduced significantly, and a kind of flattening out of eGFR, certainly less progression of eGFR. And with dapagliflozin, actually we showed exactly the same effect. So SGLT2 inhibitors work effectively for diabetic nephropathy. Thank you.
Thank you. Thank you, Dr. Malik. I think, can you just close your slide, sir?
Yeah. Stop share.
Excuse me, I think I request RX to actually close this, because if there are any questions, all the three topics are not connected with each other. Maybe if there are any questions on the chat box, let me try to have the questions so that we can ask the questions to Dr. Malik and then go on to the next this one. Are there any questions? Okay, if there are no questions, I think as you can post the questions, I'll request Dr. Azad Khan to make some comments on this particular lecture by Dr. Malik, please.
Well, I thought it was an excellent lecture. So many new things, new possibilities. So I would like to congratulate the speaker for finishing on time and giving the information. Thank you.
Thank you.
Thank you, sir. With that comment, I just have a few questions to ask Dr. Malik. That was a brilliant lecture, Dr. Malik. But then you did mention about fenofibrate, which is being used a lot in the earlier studies. And we don't seem to be using fenofibrate all that much now, because it was almost a decade back that fenofibrate made all the noise that actually helps in microvascular complications. What do you do in your practice? Do you use fenofibrate specifically aiming at microvascular complications?
I do, actually, because I read the data. And, I think the problem is that we as physicians, we go to statins as first line, and a lot of the companies push the statins and we forget. But fenofibrate, independent of lowering triglycerides, has been shown to have an impact on neuropathy. So it's not just a triglyceride lowering effect. So don't just think about it in a patient who's got high triglycerides. And there are other mechanisms of action of fenofibrate, because it's a PPAR alpha agonist that help. And I do actually, in clinical practice, if I have a patient, particularly a patient who's referred to me for neuropathy, I put them on fibrates.
I mean, irrespective of the level of the triglyceride, you put them on fibrate? Okay.
Yes.
What is the normal dosage that you have been trying, Dr. Malik?
So it's 200 milligrams. There's a standard dose. I mean, and that's what was used in the fenofibrate trial. And that's the average that was used. It's not just neuropathy, actually. There is data, good data, and I didn't have the time, obviously for retinopathy. And there's also renal data, microalbuminuria data as well, that shows, so there is an impact of fenofibrate on microvascular complications.
Yeah, because most of the recommendations that we do hear from EASD and the ADA is use fenofibrate only when the triglyceride levels are more than 500, because the only threat you have is that of pancreatitis. Otherwise, fenofibrate has nothing else to do. But that was an interesting thing, you bringing back fenofibrate and microvascular complication, and especially neuropathy. Dr. Nigam, would you like to add anything at this point of time if you are listening to Dr. Malik's lecture? You are muted.
That was a brilliant lecture, but I would have probably, there are new data from dulaglutide and all the three GLP-1s, semaglutide, dulaglutide, with dulaglutide not having any retinal risk, as you mentioned, with semaglutide. And the SGLT2 inhibitors, I think, have taken the front seat in all the guidelines, suggesting that if you have chronic kidney disease or diabetic kidney disease, then probably without even not considering the baseline HbA1c or patients having risk factors. Also, I think the SGLT2 inhibitors and the GLP-1s will probably take the front seat and push all the other agents behind. And the SGLT2 inhibitors and the ACE inhibitors have very fine synergistic effects, one acting on the afferent arteriole, the other acting on the efferent arteriole. So I think they have taken that front seat when talking about diabetic kidney disease. And again, something that we notice in India, and I'm sure it's not anywhere in the world, is the use of unwarranted use of methylcobalamin with pregabalin. I think I just prescribed pregabalin, and that is the message that should go around, because you're unnecessarily increasing cost of therapy without knowing. If you have documented vitamin B12 deficiency, I think it's worthwhile adding that agent there. But otherwise, blanket prescriptions can probably have no benefit.
I mean, I agree with you, Nikam, on that. I think Dr. Malik's comments.
Well, you're right. SGLT2 inhibitors are coming, and they're going to have, and actually there are data now, published data, that show there's an impact on retinopathy. Of course, remember the SGLT2 inhibitors had this bad signal for amputation, particularly canagliflozin. But I think if you look at some small studies coming through, they also show that that's probably not a true signal.
Yes.
So that I think we should be reassured. In terms of GLP-1 therapy, there is again data showing a benefit possibly on retinopathy. Like you say, dulaglutide hasn't shown that signal. I think it was all to do with the endpoint. So there's a big trial with semaglutide, about 4,000 patients that have recruited, and they've seen no signal to date.
Yes.
Methylcobalamin, yes. Unfortunately, this is something that is a mythical thing that all doctors, particularly in Pakistan, India, Southeast Asia, even Middle East, they prescribe this, kind of amazing vitamin B compound, which is supposed to be health reparative, nerve reparative, and there's no real evidence for it. So I think what we need is studies to show that is the case, and then people.
That also has alpha lipoic acid, which probably works in parenteral doses and not in the doses that is administered in oral tablets.
I completely agree with you. Again, the evidence there for alpha lipoic acid was generated on IV administration, was never for oral, but yet again it's been pushed and people accept it. I think in India you have do you have an approval for alpha lipoic acid?
No.
I mean, not for this indication, but then there's an approval to give it to every other patient, whether he needs it or not, because that's exactly what happens, because the pharma company tends to push it and the doctors tend to buy the idea that it's extremely good for the nerves. And of course, it's a most frustrating experience for a patient who has a painful neuropathy. So all kinds of treatments are being tried. And the capsaicin ointments are pretty popular in some corners of India, and there's always one set of patients who would love to have something to be rubbed on, especially at night when they have the painful neuropathy. And I think with that, thank you so very much, Dr. Malik. May I just know from the team, the event team, whether Dr. Inas is ready with her lecture? Is she live?
No, sir. A recorded session.
It's a recorded session?
Yes, sir.
Okay. She's already been introduced. Can you start the recorded lecture, please?
2022, and I'm going to talk about diabetes in the elderly. Life expectancy has been increasing. Advances in medical care and improved social conditions led to increased life expectancy. These are chronic health issues of older adults: arthritis, diabetes, hypertension, chronic sinusitis, visual impairment, osteoporosis, hearing impairment, varicose veins, heart disease, deformity, emphysema, dementia, and 34% of these older individuals are affected by more than one condition. Does the epidemic of diabetes involve older individuals or not? And the answer is yes. By the year 2050, there is going to be 336% increase in diabetic patients above the age of 75. The prevalence of diabetes according to the IDF is 8.8% of the total population, while according to the National Health and Nutrition Examinations Survey, the third one, in those above the age of 75, the percentage of diabetes prevalence is 17.5 to 21%. Diabetes in geriatric times is somewhat different as regards goals of therapy, choice of drugs, change in metabolism, and danger of hypoglycemia. Most studies show rise in blood glucose, especially the postprandial blood glucose, directly correlating with age. While the fasting blood glucose increases 1 to 2 milligram per deciliter per decade, we find that the postprandial blood glucose increases up to 15 milligram per deciliter per decade. And this metabolism change is due to impaired insulin release and delayed suppression of hepatic glucose output. We're going to talk about clinical presentation of diabetes in geriatrics. And what about the clinical presentation? And presentation may be confounding, and routine screening is recommended. It may be totally asymptomatic or having dramatic symptoms. The presentation may be with urinary incontinence, monoocular neuropathy, onset of sexual dysfunction, or minor and difficult to control infection. And let me now talk about challenges in management of type 2 diabetes in the elderly. Acute metabolic complications, diabetic ketoacidosis is rare, and features and management are the same like in younger individuals, but there is higher mortality due to associated cardiovascular disease. The hyperosmolar non-ketotic coma, 50% of cases occur in newly diagnosed diabetics, and it always occurs in older diabetics due to impaired maintenance of serum osmolarity, decreased thirst perception, and decreased access to water. Acute infection is a frequent precipitating factor in 40 to 60% of cases, and it's usually pneumonia. The difficulties in management are mainly due to rapid fluid replacement, which may not be feasible due to associated cardiovascular disease. Some underappreciated diabetes complications. Diabetes is a risk factor for dementia, increased 2 times dementia in the presence of diabetes, increased incidence of falls, hip fracture, immobility and disability, household work, preparing meals, managing money. And these are some diabetes complications in older individuals. Macrovascular disease, coronary artery disease is 2 times increased risk ratio versus non-diabetics. Stroke increased 2 times, amputation 10 times increased in older diabetic patients, and microvascular complications, blindness, 1.4 times increased than non-diabetics, renal disease 2 times increased, and neuropathy is markedly increased in older patients versus non-diabetic patients. Is there a risk of hypoglycemia or not? Yes, hypoglycemia risk is increased in the elderly and leading to impaired cognition. In older adults, they may have more neuroglycopenic manifestations of hypoglycemia like dizziness, weakness, delirium, confusion, compared with adrenergic manifestations with the symptoms of tremors and sweating. And these neuroglycopenic manifestations may be missed or confused as primary neurological disease, such as transient ischemic attack, leading to inappropriate diagnosis and management. Hypoglycemia is a major challenge in the treatment of diabetes in the elderly, and it may happen due to patient risk factors, advanced age, intercurrent illness, chronic liver disease, renal disease or cardiovascular disease, endocrinal deficiency, thyroid, adrenal or pituitary, loss of normal counter regulation, and hypoglycemia unawareness. It may happen also due to lifestyle risk factors like poor nutrition or fasting, prolonged physical exercise, or alcohol intake. And the third group is the drug risk factors, the use of sulfonylurea or insulin, the drug interactions with sulfonylurea. Severe hypoglycemia account for 17% of all hospitalization for type 2 diabetes in the elderly. Let's talk about chronic complications of diabetes in the elderly. Neuropathy is the most common symptomatic chronic complication. There is a progressive course with limb amputation, and the clinical diagnosis is often difficult due to age-related peripheral and autonomic dysfunction. Diagnosis is based on nerve conduction studies, and bladder dysfunction is common, but it has to be differentiated from senile enlargement of the prostate, and both conditions may lead to urinary tract infection. Geriatric diabetes is having some unique syndromes: diabetic amyotrophy occurring in older male diabetics, malignant otitis externa, which is a necrotizing infection usually caused by Pseudomonas, pyelonephritis with papillary necrosis, diabetic neuropathic cachexia with weight loss, depression, painful peripheral neuropathy, and it resolves without specific treatment, intradermal bully of the feet, periarthritis, and increased risk of accidental hypothermia. What to do for management of diabetes in the elderly, and according to ADA 2021, and to consider the assessment of medical, psychological, and functional self-management abilities of the elderly diabetic and social conditions, who is going to help these diabetics at home to decide the therapeutic approach for diabetes management, and to screen for geriatric syndromes like polypharmacy, cognitive impairment, depression, urinary incontinence, falls, and persistent pain. These may affect diabetes self-management and diminish the quality of life. To screen for early detection of neurocognitive impairment or dementia should be performed for adults 65 years of age or annual visits after 65. And the management, we have two series. One series of the postprandial blood glucose of 200 milligram per deciliter, and another series of euglycemia with hemoglobin A1C less than 7%, and what to choose. And according to life expectancy and current medical conditions, goals should be individualized according to the ADA and different other guidelines. The treatment goals for older individuals who are otherwise healthy with few coexisting chronic illnesses and intact cognitive function, they have lower glycemic goals from 7 to 7.5% hemoglobin A1C. For those with multiple coexisting chronic illnesses, cognitive impairment, or functional dependence, we should have less tight glycemic goals from 8 to 8.5 hemoglobin A1C target. For patients with relaxed target, for patients with end of life or morbid conditions or life-threatening conditions, we may have less tight glycemic targets. Screening for diabetes complications should be individualized in older adults, and particular attention should be paid to complications that would lead to functional impairment. These are the framework for considering treatment of glycemic control, the blood pressure, dyslipidemia in older adults with diabetes. When to use the statin, and this is the ADA 2021 guidelines. For lifestyle management, optimum nutrition and protein intake is recommended. Regular exercise, including aerobic activity, weight-bearing exercise, or resistance training exercise should be encouraged. For adults with type 2 diabetes, with overweight and obesity, there's a need to lose weight if possible with physical activity and dietary changes. This is the Canadian guidelines 2018, and the hemoglobin A1C targets for most type 2 diabetes should be less than 7% in adults with type 1 or type 2, and less than 6.5 in adults with type 2 to reduce the risk of chronic kidney disease and retinopathy if at low risk of hypoglycemia. From 7.1 to 8% in functionally dependent older diabetics, and from 7.1 to 8.5 in those with recurrent severe hypoglycemia or hypoglycemia unawareness, limited life expectancy, or frail elderly with or without dementia. And to avoid higher hemoglobin A1C, to minimize the risk of symptomatic hyperglycemia and acute and chronic complications. End of life A1C measurement is not recommended, but to avoid symptomatic hyperglycemia or any hypoglycemia. Diet, it is difficult to adhere to strict dietary regimes due to financial difficulty, mobility problem, poor food preparation skills, and long-standing dietary habits. No restricted diet is needed, but vitamins and minerals should be taken if the caloric intake is less than 1,000 kilocalories per day. Sulfonylurea, the clear and present danger, hypoglycemia with no warning symptoms. For biguanides, it should be used in cases without renal insufficiency or hepatic disease, contraindicated in alcoholism, severe cognitive congestive heart failure, and severe peripheral vascular disease. Alpha-glucosidase inhibitors, they are safe but may lead to severe gastrointestinal disturbance. Thiazolidine-diones, there is a fear of a precipitation of heart failure. The incretin-based therapy, DPP-4 inhibitors are safe with no risk of hypoglycemia. They are weight neutral, therefore may be attractive agents to use in the elderly, and the dose of DPP-4 inhibitors should be adjusted according to renal insufficiency if present or not. The GLP-1 receptor agonist, no risk of hypoglycemia, with the known adverse events of nausea and vomiting and diarrhea may happen. The SGLT2 in elderly patients, according to study done on dapagliflozin, there was no serious adverse events in older individuals except for volume depletion. The Canadian Diabetes Guidelines, again 2018, for older patients, DPP-4 inhibitors should be used over sulfonylurea, and the initial doses of sulfonylurea, if given, should be half of those used for younger people, and doses should be increased more slowly. Glyclazide and glyclazide MR and glimepiride should be used instead of glypuride, and meglitinide may be used instead of glypuride. What about insulin therapy in geriatric times? There may be possible medication error due to visual impairment, impaired manual ability, and limited access to injection sites. And insulin analogs seem to be more safe for geriatric people living with diabetes. By the end of my presentation, let me introduce Mr. Diabetes. Mr. Diabetes is an American patient living with diabetes, and he has gone through different US states walking and on a bicycle, and due to his exercise, his neuropathy has disappeared. Thank you very much.
Thank you so much. I think, can I have the slide of the next speaker, please? Thank you. Thank you. I would like to welcome Dr. Anant Nigam, who will be giving the next talk. A personal friend of mine, Anant Nigam, I've known him for over now 32, 33 years. In fact, he was one of the earliest one, along with Dr. Shaukat Sadikot, myself, who actually contributed to Diabetes India starting way back in 2001. He was the Secretary General and did a lot of work for almost a decade before he decided to just concentrate on his practice and take a back seat from the administrative part of it. So I welcome you, Dr. Anant Nigam. His career in diabetes spans over 38 years. He was the founder of Diabetes India. He was the CEO for almost a decade, a fellow of the Royal College of Physicians. He has delivered orations, invited lectures, keynote addresses. He has chaired scientific sessions at most of the international and national conferences, including IDF, ADA, and other meetings. He has indexed national and international publications and chapters in API and RSSDI textbook. He has served as an expert for ICMR project, was the chairman of the organizing committee of the National RSSDI 2003, and Diabetes India in 2005. And he will be giving his talk on the use of once-a-week GLP-1, the multifactorial treatment, and the uses of it. Over to you, Dr. Anant.
Thank you, Arvind, for that kind. Give me the permission to share my screen, please. Yes. Yeah, thanks, Arvind, for that kind introduction. And let me thank Diabetes India for this invitation. And Bansi, I can see here. Thank you, everybody there. We all know that glycemic control really improves the risk of, reduces the risk of complications, and the landmark trial UKPDS really showed us the way. But then, did glycemic control do everything? That was a question which bewildered researchers all over the world for years. And the STENO2 diabetes study was again another landmark study which showed that multifactorial intervention probably has been shown to reduce both cardiovascular death, cardiovascular events, and several other micro and macrovascular complications that one is likely to get in type 2 diabetes. So the whole paradigm now has shifted again in this direction with the arrival of new agents like the GLP-1s and the SGLT2 inhibitors. And in fact, all these guidelines have been rewritten. Do we have evidence with the GLP-1 dulaglutide once weekly is something that I'm going to convince you. Now, we all know that type 2 diabetes is a cardiometabolic renal disease with multiple complications, disturbing metabolic homeostasis, giving rise to CV events, renal complications, and cardiovascular complications being responsible for 75% of hospitalizations, 65% deaths, and the trio of type 2 diabetes, kidney disease, and cardiovascular disease is called a triple threat. The risk of cardiovascular disease in people in India with type 2 diabetes, this is the QRS score 3, which shows your chance of getting a heart attack in about 10 years from now. And this shows that this risk is increasing both in men and women as your age advances. But this is not all. In people with type 2 diabetes, and Asian Indians have a massive disease burden. They have abdominal adiposity. 70% of them are hypertensives. 2 to 4-fold increase in the risk of complications as compared to your Caucasian counterparts, and 40 to 70% increased risk of renal complications. And this India Today title was in 2006, The Girth of the Nation. And this is exactly what we find in our clinic data. You have abdominal adiposity, men more than 90 centimeters, women more than 80 centimeters. You can see about 40 to 50% of urban men and women are obese centrally, also having increased body mass indices, causing obesity and central adiposity, and the amount of visceral fat in Asian Indians as compared to Caucasians is much more. And that is a pretty well-known fact. But look at what Elliot P. Jocelyn said in 1927. With an excess of fat, diabetes begins, and from an excess of fat, diabetics die. Remember that type 2 diabetes never occurs alone. It occurs in the company of bad friends. And these bad friends are hypertension, obesity, kidney disease, and cardiovascular disease. The common risk factors are age, male, high cholesterol, family history, and chronic kidney disease. But these are diabetes-specific risk factors. And you have to see that if your patient has retinopathy, that also is a risk factor for cardiovascular disease, glycemic control, and duration of diabetes. Now, this cardiovascular death will continue to increase if the number of risk factors multiply. So if you have 3 risk factors, then your chance of getting these complications, age-adjusted cardiovascular death, will increase as compared to people who did not have diabetes. What happens if I don't control my diabetes? The progression of diabetic retinopathy will continue to increase, and the time taken to progression of diabetic retinopathy will be much less. So if you have clinical inertia, your patients will get diabetic retinopathy much earlier. It causes poor metabolic control and increased progression of diabetic retinopathy. But that's not all. Look at the number of macrovascular complications that come in with poor metabolic control. 67% increase in myocardial infarction, 51% increase in cerebrovascular accidents, heart failure, and a composite increase of CV events of about 62%. If I only control glucose, am I justifying saying I've reduced the risk of complications? No. The association between type 2 diabetes and mortality due to cardiovascular disease, irrespective of HbA1c. You may have an HbA1c of less than 6.9, but look at the hazard ratio there of cardiovascular disease and mortality, which means you've got to go beyond controlling, which doesn't mean that you should not control your HbA1c. It's extremely important, and all these landmark trials have proven that. But you've got to go beyond that. Something that again bothers people when you are trying to treat type 2 diabetes is the risk of hypoglycemia and weight gain. And these are swinging on this balance. As you try and get your HbA1c down, you're pushing up the chance of weight gain and hypoglycemia. And this increases with the reuse of sulfonylureas, meglitides, and insulin. Does hypoglycemia cause cardiovascular risk? Well, that is always hanging there. And the data from the Accord study said probably it was not an innocent bystander, but probably the signal was there. And look at the weight gain in all these clinical trials. The UKPDS, almost 5.3 kg with sulfonylureas and insulin. In the DCCT, in the Accord trial, more than 10 kg weight, rosiglitazone and glyburide. And then look at hypoglycemia, intensive versus conventional therapy. And you can see the risk of hypoglycemia. And hypoglycemia, again, is a major limiting factor in meeting your tight glycemic controls. And this weight gain or obesity, all forms of obesity, increase cardiovascular risk. So there has been really a paradigm shift, as I mentioned in my opening remarks, in how we understand type 2 diabetes and how we try and manage in 2022. Previously, it was all about blood glucose and glucose control. Now it's about glucose control with no hypoglycemia or weight gain, but also aiming for weight loss and paying specific attention to cardiovascular risk and renal risk assessment and management. What do the guidelines and consensus statement say about it? So in the next 10, 15, 20 minutes, I'm going to answer what is multifactorial intervention, which we are going to talk about today. Does multifactorial intervention help in reducing microvascular and macrovascular disease complications in type 2 diabetes? And is there evidence that GLP-1 receptor agonists, specifically once weekly dulaglutide, help in multifactorial risk reduction in people with type 2 diabetes and thereby decrease the risk of CVD and renal disease? The answer to this is yes. Now, this is the steno-2 diabetes that I was mentioning about, a very simple study conducted in 160 patients with type 2 diabetes who had persistent microalbuminuria. And they were put on intensive versus conventional therapy. And the intensive therapy was anti-diabetic therapy, trying to get HbA1c less than 6.5, RAS blockers trying to get blood pressure less than 130/80, statins trying to get cholesterol less than 175, and low-dose aspirin for primary prevention. The study was designed for a period of 7.8 years with a mean follow-up of 5.5 years. And you can see here, within the first 2 years, the graphs started separating. And there was almost a 13 to 20% reduction, absolute risk reduction in CV events and CV death. But then a later follow-up at 21 years, look at what happened. Secondary and tertiary endpoints showed significant improvement in all-cause mortality, CVD mortality, CVD events, autonomic neuropathy, and also microalbuminuria. And this, according to Peter Gate, was a 7.9 years gain of life. There was, in addition, a 70% decrease in hospitalization for heart failure and 69% decrease in stroke. And this study was published this was 2018, where they showed the follow-up at 21 years. And this probably has now forced or advised, this advice comes from the American Diabetes Association 2022. If you have to really look at pillars of management in type 2 diabetes, you've got to look after glycemic management. Never ignore this. You've got to tighten blood pressure control. You've got to manage lipid control and use agents which have cardiovascular and kidney benefits. You also have to very importantly remember that these risk factors should not be ignored. Duration of diabetes, obesity, a simple thing that you can measure in your clinics, waist circumference, is an important cardiovascular risk factor. Hypertension, smoking, premature history of premature coronary artery disease, and presence of albuminuria or chronic kidney disease. So just remember these 4 important things that would probably help you to decrease cardiovascular risk and complications. Now, coming to this picture here, which shows you anti-hyperglycemic agents as of today. Now, the most important ones being used are DPP-4 inhibitors, the glitazone, sulfonylurea, and insulin. But look at their risk of hypoglycemia. SUs and insulins increase risk of hypoglycemia. If I come to cardiovascular benefits, none of them give you cardiovascular benefits except being safe. They're all cardiovascular safe. Potential benefit may be pioglitazone, but we don't use that so often. And what about kidney disease? All of them have neutral effects as far as improvement in kidney function is concerned. Now, what happens with the only other 3 agents left are metformin, SGLT2 inhibitors, and the GLP-1s. Let's see the GLP-1s. The efficacy is high, hypoglycemia is low, loss of weight, and look at it gives you cardiovascular benefits. And dulaglutide stands out very typically here, progression of DKD, and also dosing. You don't have to adjust doses even in patients with chronic kidney disease. And this is the reason why guidelines are changing. Look at the ADA 2021 guidelines. Here it said you should consider independently of baseline HbA1c, individualized targets, or metformin use. But look at 2022. It says recommend straight away an SGLT2 or a GLP-1 if your patients have individualized, if your patients have ASCVD or indicators of high risk. And I've already shown you the indicators of high cardiovascular risk. I will again show you that, or heart failure or CKD. The American College of Cardiology says it should be independent of glycemic control with proven benefits. And the American Association of Clinical Endocrinology again says independent of glycemic control, but says use long-acting GLP-1s with proven efficacy. Trying to read between the lines, patients at high risk for ASCVD include those with end organ damage, like left ventricular hypertrophy or retinopathy. If your patient gets you a report with retinopathy, he's heading for a cardiovascular event. So look at that. Or multiple cardiovascular risk factors like age, hypertension, smoking, dyslipidemia, and obesity. Oh, we say, this guy is 65 years old, so I shouldn't be using a GLP-1 or a SGLT2. Well, that's a story of the past. You've got evidence that these are risk factors for cardiovascular events. Now, coming to the GLP-1s, we have these available in India, the ones in the orange. Dulaglutide effects on multiple risk factors: HbA1c, body weight, overall difference here. You can see here urine albumin decretion, estimated GFR was improved, and systolic blood pressure was improved. And this is a very interesting randomized trial where dulaglutide was added to conventional therapy and data was looked up at 3 months and 9 months follow-up. And these are so important, very common data that we see for all patients in the clinic every day: systolic blood pressure, diastolic blood pressure, weight, BMI, total cholesterol, HDL, LDL, triglycerides, fasting plasma glucose, GFR, CK, eGFR, microalbuminuria. And you can see here at 9 months, you can see the p-value. There was an improvement at 3 months and again an improvement at 9 months. Very clearly showing that dulaglutide is working at all these vascular health indices in people with type 2 diabetes. And these are the baseline cardiovascular risk factors which we've been talking about for the last 10-15 minutes. Look at fat, another very important epidemic which is around, which is NAFLD. And here it shows that dulaglutide decreases liver fat, decreases gamma GT levels, improves liver stiffness, and also probably increases non-significantly pancreatic fat content, and thereby is probably another very important agent that I would consider in using in people with type 2 diabetes and liver fibrosis. Talking about the cardiovascular outcome trials, and look at the dulaglutide trial, the REWIND trial. I'm just going to point out 3 important things. 9,000 individuals, the longest trial, 5.4 years. Baseline HbA1c, pretty well controlled. And then also you saw the cardiovascular benefit. Cardiovascular risk factor was present only in 31% patients. So they were more like the patients that you see in your clinic every day. 65% did not have cardiovascular disease, only had risk factors. And the HR hazard ratio was almost the same. And what did it show here? Similar hazard ratio, 0.88, 0.78, 0.74. But remember that all those trials had more patients with pre-existing cardiovascular disease. So they were more like the secondary prevention population trials. And so dulaglutide reduced cardiovascular both in men and women with or without previous cardiovascular disease and had an effect size similar to that observed with the other GLP-1 receptors, mainly in the secondary prevention populations. Now, dulaglutide is the first, the only GLP-1 to demonstrate benefits, both primary and secondary prevention of cardiovascular disease. And you can see here, overall 0.88, people who did have cardiovascular disease, 0.87, who only had risk factors, 0.87. So it reduces MACE events in adults with or without known cardiovascular disease. And that has been really updated in the ADA guidelines here. To date, the level of evidence to support the use of GLP-1 receptor agonists for primary prevention is the strongest for dulaglutide, but lacking for other GLP-1 receptor agonists. And there has been consistent benefit trials in patients with or without established cardiovascular disease. Talking about microvascular complications, we were talking about in Dr. Malik's talk also, and here is benefit of dulaglutide in eye complications, laser, anti-VEGF therapies, kidney, new macroalbuminuria, or 30% fall in eGFR, or chronic renal replacement therapy. The red line shows you dulaglutide and the blue one is placebo. How do they do it? We all know how they work to reduce glycemia, working at the pancreas, decreasing hepatic glucose production, decreasing gastric emptying, improving, working at the brain, decreasing appetite, and also decreasing adiposity. But what about reduction in atherosclerotic plaques? Probably has an effect at the level of the endothelium and the smooth muscles and the macrophages, and on the regulation of plasma lipids, and thereby decreasing and the progression of atherosclerotic plaques. Inflammation also is very important, which it probably blocks. There are 3 GLP-1 receptor agonists available in India. The boxes ticked in favor of dulaglutide are the maximum, except that it's not oral, but people in several patient preference studies have shown that people prefer the once weekly injection versus a lot of limitation when using oral semaglutide and a daily injection of liraglutide, of course, with all other benefits which I've shown and enumerated, and also being the first and only GLP-1 for both primary and secondary prevention of cardiovascular events. So friends, type 2 diabetes is a cardiovascular renal disease. It comes with cluster of risk factors. The residual CV risk factor is always high despite good control. It's important to have a multifactorial approach in the reduction. Once weekly dulaglutide provides significant benefit by addressing multiple risk factors in people with type 2 diabetes. Guidelines recommend GLP-1s independent of baseline HbA1c when you have any of these things present there. And the size that it gives you, the effect that it gives you, is as good as agents which were used primarily in secondary prevention trials. And as I mentioned, it can be used for both primary and secondary prevention of complications and cardiovascular disease in people with type 2 diabetes. Thank you very much for your attention.
Thank you, Nigam, for a brilliant lecture. I should really congratulate you on that
Thank you.
lecture. And then you've very clearly taken us through the entire spectrum of how the GLP works and how once a week dulaglutide is going to change the entire treatment spectrum over a period of time. I think, in my presidential speech also today, I was just mentioning that India has different segments. The biggest problem that we face is we do accept that GLP-1 once a week is a great boon in the management of type 2 diabetes. But unfortunately, the cost becomes a big problem in a country like India, where the segments are different. I mean, even though we have a great drug, unfortunately, we'll not be able to use it in majority of the patients. And that is where the generics of SGLT2 are slowly trying to take over. How I wish the cost of once a week dulaglutide is going to be affordable by majority of the Indians. I mean, apart from that, every single thing that you said, we as doctors always say that I think this is the greatest discovery. And we have heard DeFranco speaking so passionately about the GLP-1s. And what is your personal experience on using once a week dulaglutide, and how many of your patients are on dulaglutide?
Oh, I probably have innumerable. And I probably have about, I would say, 6-7 prescriptions a week on dulaglutide once a week. And because of the obesity that you're now seeing mushrooming around India, I think several of them are also in combination with the SGLT2 inhibitors. But alone, a GLP-1 with basal insulin, a GLP-1 with a small dose of sulfonylurea, a GLP-1 with SGLT2 inhibitors, a GLP-1 with metformin, I think they're excellent combinations.
I know.
And I have to really emphasize the point that we are not treating only glycemia. We are preventing complications.
That's
so
true.
As I showed that cardiovascular risk factors today include age, hypertension, obesity, duration of diabetes. When you talk to a patient in the clinic, you say, oh, well, it's HbA1c is 7.9. I could get it down with any other thing. But what I'm trying to imagine is always, what is he going to do 35 years down the line? He's only 40 years of age. If he can afford, I know affordability, cost is a very important constraint and also a factor which I consider. And correctly chosen patients have been on dulaglutide or GLP-1s for 7 years, 8 years, 10 years. I have patients who are just vouch for it. I don't have to do anything because everything is under control. They've been able to reduce their weight, control. The blood pressure drugs come down. Drastically, if you put these patients on GLP-1 and they lose about 5 kilograms weight and 3 centimeters of their waistline, their telmisartan dose comes down from 80 milligrams to 40 milligrams. Within 6 weeks or 10 weeks, one antihypertensive agent is knocked off. If he's on sulfonylurea or any other agent, those doses have to go down. So overall, it gets you many benefits. But the most important benefit is preventing patients from going to the hospital for a stroke or a myocardial infarction or even kidney disease. SGLT2 inhibitors are super agents. Again, I am a fan of both these agents. But then again, urinary infection, genital infection sometimes can be disastrous, as abdominal discomfort with GLP-1s is also there. So, it's really a balancing act and really trying to convince patients that these agents will have side effects. You have to choose which one, which helps you most, continue that.
Very true, very true. I think in all affordable patients, who can tolerate it well, I think GLP-1 should be the drug of choice, and especially with once a week injectables. I think even the geriatric population is something that, you can look forward to. And once a week is definitely, there is that affordable class in India. You need to just choose, maybe spend time and explain to them.
That's why all the Teslas and Mercedes and all are coming to India. That's the reason. Because the people can afford, people want that answer from you that this is the drug to use. They probably don't get it. And prescriptions are not written on time. And physicians, I'm not blaming anybody, physicians try to find the easy way out. Who's going to spend time on side effects? If he gets a nausea or a vomit, he's going to call me. Let him call him. You've got to be passionate. So that is something that hinders us from using these agents. Why do we use insulin? We use insulin. We know it causes hypoglycemia. And that's even worse. So, you could fall unconscious. So I think we'll have to really think about preventing complications rather than controlling only glycemia.
So I think the message is you shun the inertia and then look at your affordable class, and if you can be convinced, I think this is the drug to be started in most of your patients. Thank you very much, Dr. Nigam, for that wonderful lecture. I think we just exceeded the time limit by 2 to 3 minutes. Now I close this session here. Request Dr. Sanjay Reddy to take over